So it's exactly 11 hours now, and I want to welcome everyone to this webinar being organized by the Nigerian Academy of Science on COVID-19 response in Nigeria, the science and the policy. And to set the ball rolling, I want to call on the president of the Nigerian Academy of Science, Professor Mosto Onoha, to start off with the opening remarks.
Yeah, thank you very much, Inka, our moderator. I'd like to welcome everybody to this webinar being organized by the Nigerian Academy of Science. The Academy of Science is the peak scientific body in this country, a body that is dedicated to the promotion of science, technology, and innovation for the good of Nigeria and for the benefits of all. The Academy is about 43 years old, for those who do not. It is a body of distinguished scientists, men, women who are acknowledged internationally and nationally, particularly in their fields of scientific endeavor. Group of these are inducted into the fellow and recognition of the contribution they have made to science. For all these 43 years, the Nigerian Academy of Science is been playing its the Academy has routinely organized like workshops, seminars, and all categories of stakeholders on scientific issues that are perceived to be of national or international significance. And now here we are, since 2020, who could have, the coronavirus disease has completely changed the way we work. It's on the earth. Millions of people are out of work. So we also thought it meant to bring again together key players. We can't bring them physically as we would normally do, but virtually to discuss the interplay between science and policy in responding to COVID-19, and to bring together representatives from both the policy section and the scientific community to discuss our response. When I say our, that's our nation's response to the COVID-19 pandemic. How are we faring? How are we applying science to the control or to our efforts? What are the next steps we should do? Before we even go on, I know the moderator will introduce the people we have picked right from the onset of this pandemic.
I don't know whether it's only me. I can't hear the president of the academy anymore.
Yeah, sorry. It looks like I lost the audio a little bit, but I will just quickly conclude if you can hear me. And
yes, we can hear you now. We can hear you, and we can see you
sorry
again.
about that. Yeah, these things happen. So I just want to say before we kick off that I'm personally very pleased to have our experts, both from government. The NCDC has been doing a fantastic job, especially allowing science to dictate how we react. And I don't want to speak for the NCDC DG, but I'm sure he will make that clear from what they have been doing. So this is why we are here. We will discuss this, and because a lot of lives have been transformed completely the way we work, and we have to rely on science. I just want to welcome everybody to this meeting, to thank all those who have logged in. I know a lot more. There was a lot of interest in this. We can't probably have everybody, but we have the key people we need. I welcome the NCDC Director General. I welcome our representatives, fellows of the Academy, and I'd like us to go on with this program to hear the experts, and if need be, I'll come back again to talk to you for a few minutes before we wind up. Thank you for listening. We're expecting a very robust participation even when the question and answer starts. Over to you, moderator.
Thank you very much, dear President. You've set the ball rolling properly. And we will now go to the panelists, and it's a distinguished assemblage, if I'm permitted to call it that. Two distinguished fellows of the Nigerian Academy of Science, interfacing with the person right at the nerve center of battling the COVID pandemic in Nigeria, the Director General of the Nigeria Center for Disease Control, NCDC, and somebody right at the front line of caring for those who have become victimized by this disease, or who have I think victimized is still an appropriate word to use, because it's something that's certainly not welcome by any one of us. It's just about 9 months now that the severe acute respiratory distress syndrome coronavirus 2, which is the official name of the virus, burst upon the consciousness of everyone. First of all, restricted to Wuhan in China, but then about 7 months ago, in January, after it was reported to the World Health Organization on the 31st of December, it's something that everybody gradually became familiar with. And since then, it has upended life as we knew it on this planet. It's affected practically every country on the planet, and it's touched upon more or less every human being that's living on this planet. Things certainly are not being done the way they were done last year. All travel more or less has been either stopped altogether or completely altered in its pattern since I would say about 5 months ago. From about the middle of March, more or less, all the countries in the world were shutting themselves down one by one and preventing people from moving from one part of the world to another. Scientific conferences as we knew them no longer hold. Well, there are other meeting points, such as this one that we are holding today. So let's get on to listen to these different viewpoints from the policy perspective, from the science perspective, from the patient care perspective, and we have the appropriate cast. Let me just briefly introduce all the members of the panel. I do believe that we are all present. We are all present. I can see that Professor Oyewale Tomori is here. He is the lead speaker, is also the chairman of the Ministerial Expert Advisory Committee on the COVID-19 response in Nigeria. He happens to be the immediate past president of the Nigerian Academy of Science. Then we have another fellow of the Academy, Professor Issa Hussaini. He is a distinguished pharmacist and also a politician. He is a pharmacologist affiliated to the University of Maiduguri, and is also the Borno State Commissioner for Higher Education. So is bringing in so many different perspectives to this discussion. Then we have Dr. Bodela Dipo, who is the incident manager for the Oyo State Emergency Operations Centers, overseeing all the isolation centers in the state. I believe, although I stand to be controverted, I think Oyo State has the largest number of isolation centers of any state in the country, even more than Lagos, which has many more cases. There are so many more isolation centers spread all around Oyo State, which of course has a much larger geographical area than Lagos State does have. And finally, but not the least, probably the person that can give us up-to-date information about the COVID response in Nigeria, because it's right at the nerve center. And that is Dr. Chikwe Ihekweazu, the Director General of the Nigerian Center for Disease Control. So I want to welcome all the panelists. I'm sure we are going to be treated to a feast of new information and new perspectives to dealing with the problem of COVID-19, the disease caused by the SARS coronavirus 2. I will like us to start by listening to the chairman of the Ministerial Advisory Committee, Professor Oyewale Tomori, to give us the lead presentation and set the platform for the subsequent presentations. So it's my pleasure to call on Professor Oyewale Tomori to take the floor.
Thank you very much. Can I share my screen? Or will you share it with me there?
You can share your screen.
No, I think they can transfer hosting rights to you so that you can share your screen.
You can share your
screen. You can
screen.
control it directly.
Oh, okay, I'll try and do that. Can you see them in my screen now?
No,
Can
sir.
you see my screen?
No, sir.
You can't see it yet.
It's
Just
not yet shared, so share your screen. May I request that those who are not actually speaking can switch off their video so that we can manage the little bandwidth we have.
For us, yes.
So it's only those who are speaking that should switch on their video. I'm going to switch mine off now too as well.
Can you see it now?
Yes,
Yes,
sir.
it's beginning to share now. Yes.
Okay. Now
We can see your screen. Yes, we can see it. Your screen is displayed now, so you can proceed.
Okay, thank you very much, sir. Thank you for the opportunity to to talk about this COVID response in Nigeria. I amended the title a little bit because I thought it would be important for us. We can't talk about science without talking about the scientists. Nor can we talk about policy without talking about the politicians, because those are the people who drive the science and the politicians drive the policy. If we take them out of it, I think we'll probably not be saying what we should do. I think the screen I'm sharing, I don't know what is happening. Can you see my second slide? I hope you can.
Yes, sir.
Yeah, okay. I have I have just two slides to talk about, to bring the whole thing. I wanted to look at the period, the pre-outbreak period, what we're doing during this outbreak. And I want to take advantage of looking into the future and then end up with matters arising, which I thought. First of all, on the pre-outbreak, what was the policy and what are the politicians doing? When the thing started in Wuhan, way back, I think about in December, but early in January, February, we had a talk with the Ministry of Health people and kind of alerted them that it was time for us, what we did for Ebola. I mean, we should also begin to do that. And so the border monitoring was set up at the border, just the two, I think mainly Abuja and Lagos. But to be frank, and because I had 2 or 3 personal experiences with that border thing, and I thought, I don't think we're taking it as seriously as we took. I gave one example of the lady who was supposed to be taking her temperature. I had her face somewhere else talking to somebody asking about the food she had sent her for, and which had not arrived. By that time, 5, 6 of us had passed, and she didn't even look at the screen. And so I went back and I asked her, I said, Madam, you're supposed to be looking at this thing so that in case anybody who has, and it was like, she gave me that look, you know, that look we get from Nigeria. Are you going to cheat me my job? And so that became quite a major issue. And so for a long time, we were expecting the cases to come from China because, you know, a lot of our people go to trade with China. And so we're looking that if there's going to be any case at all, you know, it's going to come from there. But it didn't. No, not because I don't think there was no case coming from China, but because our system did not detect it. And so when we detected the first case in February 27 or thereabouts, I think to me, it was more by chance, not because we were that prepared. Because the case went to a consultant who was working with that factory in Ogun State. And they then got to their clinic in Lagos, who then informed the government. And the question I was asking is, if there had been ordinary me that I got sick and I entered into Ihekweazu hospital, will the government be informed? We're just lucky that the group there informed the government, and that's what then alerted us that we had a problem. But to be fair to the government, thereafter, especially Lagos State government, when that came out, they ran out, I mean, they came out in full force, based on the experience they had with Ebola. And so it wasn't quite I wasn't surprised that Lagos State did that. But for quite a long time, it was only Lagos State that was actually doing anything. The Ogun State, where the first case was actually reported, they didn't get on board until quite a long time. And so we were able to monitor a few of the borders, eventually Lagos and Abuja. But then what about Semeboda? What about the other borders? But I'm glad that, you know, eventually, as I said, the NCDC, everybody came on board and started doing what we needed to do. And at that point, action took place. I'm going to talk later about some of the constraints that the NCDC had, and also the constraint that even the government had. But the constraint not caused by any other thing, but by our own failure to do the right thing in times past. I'll talk a little bit about that. What about science and the scientists? The academic came out even before the big issue and alerted the country on the need to look at COVID and lock down the place and do certain things. Because we were thinking we're crazy people at that time, talking of lockdown. At the time we talked of lockdown. But you know, we have a saying in our own different areas that if you don't have a mother, if you don't have anybody around you, you make sure you don't get sore at your back, because nobody's going to be able to help you. Nigeria definitely had no mother, no father, as far as health relation was concerned. And we were ready, we weren't prepared for the sword that was going to catch us at the back. And that's what caught us, when we got the epidemic that become. Apart from the academy and a few individuals, I don't think we as scientists came out, you know, to do more than allow the country in our discussion, in our relationship. Again, some of our own scientists actually came to compound the issue, which I'm going to be talking about later. I'm moving on to during the epidemic. What about the policies and politicians? The government set up the PTF, which was expected, and used a law, 1926 law, to bring the country under emergency rule. In hindsight now, one would have thought perhaps before that time, maybe the federal government will have called all the state governors together, tell them that we have a national emergency in our hand. This is what we're going to do, rather than just sit down there and set up the PTF. And then state now are now claiming a concurrent list of health. I mean, the federal government can't just do that. And of course, some of our top lawyers even challenge the government about whether they, they have the right to do that thing. When epidemic comes, when pandemic comes, or all those laws, the government has that right to bring in an emergency situation. But I think we needed to have informed our people, informed the other participants in the government, the states, particularly with the law about this concurrency of health, and brought them together so that we can, when the PTF was set up, then everybody will work together with PTF. But what did you get? We had discordant voices coming in from different states. I will mention Cross River, I will mention Kogi State, and even Kano, and a few others, where, whatever the federal government was saying, nobody was actually interested in that one. They were doing what they liked. Even up to today, Kogi State still says, doesn't believe that, the governor doesn't believe that we have COVID in Nigeria. And until the Cross River governor was finally exposed and caught, he was propounding theories that were no mid science, and using his position to confuse people the more. And we had a few scientists on the ITV in Benin. We had a so-called professor who came and said, there's nothing like COVID, this and this and this and that, and said all sorts of things. 3 months later, he comes around to tell the world he has now found the cure for COVID. And I said, that was the time when people asked me, I said, well, there are professors and there are also professors. So these are some of the things. So also in the time of the policy of the government, I think there was this lack of concordance an agreement to get things done. And because we're getting different messages coming from people, that led us to the point that the people didn't even believe what the government was saying. And so when it was time to prepare, I remember telling Chikwe himself that I don't envy you, but I admire what you're doing. I said, what you're doing now, you're making ammunition at the war front. We're pouring icing on a very rotten cake, because you should not be building laboratories now. Those laboratories should have been there over these 60 years, and it's just for you to repurpose them for the work that is on. And so back again to, I already mentioned some of our scientists. Some of us were charlatans. We didn't know what we were talking about, and we were preparing theories they didn't know anything about. And then we had miracle cure merchant cure merchants who were, without seeing one case of COVID, declaring to the whole world that they have found the cure for COVID. And I'm kind of imagining, I can mention, I don't want to mention names, but there were 2, 3, 4 of them who had cures already, even before we had the first case of COVID in Nigeria. So again, some of our scientists, and unfortunately, people who listen more to such people than to you and I that are making this thing. Now, that's how far this is. Again, I think I think Chikwe is going to talk a little more about that. But one of the things I found a bit worrisome was the fact that even at this time, states still have control, or whatever you call it, over the numbers of cases that are coming from their place. We have a national emergency in our hands, and states are making claims to numbers and things of that nature. And what we're getting, as I've always said, we're running after the epidemic, because the numbers are not coming out at that time. If 600 cases are positive today, it does not mean that they were positive today. They were positive from the date of sample collection. And if we had had all the information and people have sat down to look at the data, they will have been able to disaggregate this in according to the date of sample collection, and therefore be able to give us a proper information about what type of epidemic are we getting. So when you bring in 600 samples on today as being positive today, and you add it onto your graph, you are getting result graph, not epidemic curve. These are some of the issues, I think, and I think opportunity for us and scientists that have come together. I keep referring to Johns Hopkins, I keep referring to our world in data. What happens in those places is that it's not, they take data from wherever source they can get it. And they have people, volunteer scientists who sit down together with them, do this analysis and prepare it to the administration, say, this is the direction this epidemic is going. This is what we need to do. I think we need to do more of that in this country. The staff at NCDC, I think they're overwhelmed. Obviously, I mean, everybody is overwhelmed. And therefore, they can make do with a little bit of support from a few volunteers, from the Nigerian Academy of Science, from biostatisticians, all the people who will readily, offer this service for the sake of the nation. And I think we should take full advantage of that, and then be able to. And then when some of our colleagues come up with all these false information, it is in our position to challenge those people and let the people know exactly that this information is not right. We cannot let people who carry tags of being scientists doing what they are doing. Now, let me look into the future. Where do we go from here? And I think it is important for us to learn from what is happening. In fact, this is the time to sit back. Why are we where we are? Why is the situation? People are saying, oh, our numbers, nobody believes our numbers. A lot of people don't believe our numbers. I don't believe the number we have is the right number. I think we have more than that. These are the kind of things. So what do we do? Why did we get to this stage? Well, for example, did you take Chikwe 6 months, or about 3-4 months to build up laboratory up to the 62 that we have now? I think they're more every day. Great work they're doing, but is it the time to be making ammunition at the war front? And should we now look back on what made us the way we are? Why are we where we are now? Why are we doing what we're doing now at this time when all these things should have been ready? For example, why are different groups of ministerial officials working in silos? Why, for example, couldn't we from day one repurpose some of the gene experts? I know there are problems. They may not be reagent, they may not be other things. But now I'm told at least 19, 20 of them are being used for the COVID tests. If people are saying, oh, maybe what of their work, of course, then you amend, you recruit more staff, do a 24/7, do shifts, and let these things be made full use. According to the records, we have about 300 or 400 of those gene experts. I know they have problems. Some of them don't even have BSL-2 labs. Those are the things, facilities. Those are the things we need to address, as they come, when those problems arise. So where do we go from here? Let's learn from what we have done now. How can we make sure that when the future epidemics will not be as where we are? And in case of we as science and scientists, we need to update our information. This is an evolving disease, and new information is coming out. WHO comes in with one thing today, another thing tomorrow, and people are blaming WHO. I don't blame WHO. What WHO is saying is doing whatever it is based on available evidence. If you don't study, you won't know what the new evidence is. Take the issue of is it airborne, is it droplet borne, or whatever. Of course, I've always believed that there's some airborne aspect to this. But then there was no one. So WHO says, until I get the evidence, I'm not going to, just like the academy is a science-based, evidence-based organization. So those who are saying WHO is free-flopping, I don't think so. I think they're doing with what evidence and making decisions based on that. Now, let me look at matters arising. Involving the public, and one of the greatest errors which I think this government made was to arrogate to itself that it was the one controlling the COVID epidemic. It's not. I always say, COVID is not going to kill my government, but COVID is going to kill the individual. Therefore, who is more important in COVID release? It is the individual. Government should have shifted that emphasis on letting people know. It was only about 3-4 weeks ago that we were complaining, oh, public are not doing this, public are not doing that. Yes, of course, public will not do that because you arrogated yourself that you are the one controlling the epidemic. That was a big error. From now on, I think the public aspect should be taken more into consideration. No matter how many times we locked down or locked up, the cases were surging because the people were not playing their role. And in many other countries where they have followed those things already, they brought down the epidemic. So there's nothing strange about that. It's been proven. If you wear your mask, if you wash your hands, you do that and all that, then, but people are looking for excuse. Oh, how can you wash your hand when there's no water? How can you do this when there is? Why don't you address those ones rather than say because of their excuse and then get yourself killed? That's on the one. Involving scientists. I've already mentioned something of that nature. On the issue of the laboratory system, I've been working in the laboratory system for all these years. It's such a pain to me that at this stage, this is what we're still doing with laboratories. We're supposed to have had fantastic network coming in this country, but government policies, even no matter how individuals like Chikwe try to get things done, the policy and even the fight within amongst us, among the so-called scientists. The 5 minutes is even hampering the situation more than that. Those are things we need to begin to address. Now, let me end by talking about vaccines. Central Bank came up with some grants and said, oh yeah, we were ready to sponsor vaccine and something of that nature. I said, yes, of course. But then they want the finished product. I said, how can you want to give me money to make my roof when I don't have a foundation for building the house? That's what they're putting the horse before the cart. It's not that there are no scientists in this country, there are, but there's an environment for scientists to work. You can bring a carpenter to your house and tell him to fix your door when he has no nails, he has no hammer, he has no this thing. What Nigeria is lacking is not the scientists. What we are lacking is that creative environment, that enabling environment for the scientists to function. Individually, you may be able to do one thing here or there or there, but then generally, if you are depending on NEPA, if you are depending on water, you're depending on importation, you're depending on all those things that will make the environment conducive, then you begin to see where we have a problem. I hear diaspora saying, no, the way things are doing things in Nigeria. I give them 1 day, let them come home for 1 month and see what they will produce under the environment. And then reverse, take a scientist from Nigeria, take him overseas to that environment and see whether he will perform much better than those ones who are in the diaspora. So the important thing is the environment. And now this is where scientists come in. We have to put our voice up there to create that enabling environment for us to function. Otherwise, our talents are being wasted. Let me finish with a story, which I've told others before. Last year, we had the 50 years of Lassa fever, and Chikwe's group set up this international conference. In one of the seminars, I think before or after, I can't remember, and I was sitting on the panel with a few people. The guy who came in as one of the experts to help us in Nigeria was a person who had come into Nigeria in 1986 or 87 to learn how to deal with Lassa fever. I took this guy from Ibadan to Lafia to this and that and all those places. And then he went back to his country. 30 years later, he comes back to advise me on how to deal with Lassa fever in my country. It is not that I've gone so stupid over the years. It is because my country has not, the same country that made me the scientist I am, has now created the environment, a toxic environment, to make me a novice in my country, to make me, I don't want to worry what I use. So I think on that note, I try to bring some words for our discussion. Thank you very much, moderator, sir. Professor Omigori. Over.
Thank you very much, Professor Tomori. That was excellent time management. You stuck strictly to the time allotted to you, and I hope the other panelists would do the same so that we would have sufficient time for questions and answers later on. So now, the next speaker I'm going to call upon is the Director General of the Nigerian Center for Disease Control. So he can tell us what the situation is now in terms of the COVID response in Nigeria. I'm sure a lot of questions will be coming to him later on. I could already see some that have been put in the question and answer panel. So, but let's listen to him first before we bombard him with questions. So Dr. Chikwe Ihekweazu, please, you have the floor. You have 15 minutes too.
Okay, 1 minute, just trying to share my slide, my screen. Can you see it now?
Yes, sir.
Okay.
Yes, we can see your screen. Thank you.
Thank you very much.
You can maybe you make it slideshow so that maybe it becomes bigger.
Is it not on slideshow?
No, it's not on slideshow mode. It's still on the review. Okay, yeah, it's on slideshow mode now. Fine, excellent.
Okay. Okay, so thank you very much, senior colleagues. Thank you for inviting me to this important session. Thank you, Mr. President, and all the members of the Nigeria Academy for Science. Yes, obviously, we're going through one of the biggest public health challenges of our lifetimes, but we're also going through one of the biggest assaults on science in our lifetimes, as well as one of the biggest opportunities for science in our lifetimes. So there are many conflicting intersections of what is going on at the moment. And beyond looking at what is happening in Nigeria specifically, I would dare to suggest that everyone has an existential challenge on this group. Is how do we defend science as the underlying and underpinning principle on which to make decisions in epidemics of this nature? That principle is being challenged very deeply in our society and in many societies. And if we don't raise our voices to defend this underlying basis on which we have built our various careers, whether it's in medicine, in pharmacy, in public health, then we collectively stand a big risk of losing it all. So I just want to say this before I go into my slides, that we need your voices. Keeping quiet in this time is not an option. If somebody comes up with a cure of something and we all leave it to NCDC to go and defend, it will not work. We need the scientists that really understand the basis on which our professions are built. We need the Nigerian Academy of Science to be much more vociferous in their use of their voice, your voice, in defending science as the underlying principle of how our response should work. So having said that, I'll try very hard to keep to time and just go through a bit of the response, because sometimes a lot of the hard work that we're doing is lost in a lot of hyperbole and criticisms in the public space. So I thought that for an important audience like this, it's important to go into a little bit more detail to understand how this response is evolving in our extremely complex country. So I'll go through a quick introduction, Nigeria's response, our public health response, and a few thoughts about science and policy. But just a few words first on the Nigeria Center for Disease Control. It's a fairly new organization. Barely any Nigerian, apart from those involved, knew about this. Enabling law was just in 2018. We had a first national coordinator, but I'm the first director general. So a very new organization with a mandate as described in the slide that you're faced with. But the critical thing is to look at slide point number 3. Our mandate is primarily to support the states in developing the capacity to respond and to respond. And yes, we will lead national responses, but we will always work through the states. And that is not a health issue. That is a definition of how our federation has come together. So I cannot, very often you will hear in the media, NCDC does not do safe burial in Oyo State, or NCDC has not picked up patient X in Sokoto. Of course, NCDC is not responsible for picking up. These are state government responsibilities for which we support them to do. But we cannot come out in public and say, I cannot come out and say, listen, this is not my responsibility, because I have to support the state government. So I'm caught in a catch-22 situation, and I have hoped for a lot more support from people that know, but very often people keep quiet in the midst of what is going on. In terms of the COVID-19 situation, I think I won't spend too much time on this. We all know the timelines in terms of what has happened from the very first case in China and how that evolved. I was actually part of a WHO group that went to China in February to understand what was going on there. I hope that some of that knowledge helped some of the early actions that we took in preparedness. Few people knew. We set up an emergency operations center way before this was in the public space, and supported Lagos and Ogun State significantly. Up till today, we still have a team of 40 people in Lagos supporting Lagos State every single day in the response. It is not heard about anywhere, but this is the level of support that we have consistently provided to states, so that we have had a team in Lagos for 6 months, and 40 is the lowest number of people we've ever had. So you can imagine the resources that we have deployed from NCDC to support the states. Every state now has confirmed cases. On the 6th of July, Cross River reported its first case, but we all know that Cross River has had cases from very early on in the year, most likely. We now stand at about just over 46,000 confirmed cases. The epi curve is on slide 7. Yes, this epidemic curve does not obviously represent all the potential cases in Nigeria, but no country can claim that its epi curve is fully representative of the cases in their country. We are limited by our diagnostic options. We only have a very complex PCR methodology for diagnosis. No of the antigen antibody tests being bandied around provides sufficient specificity and sensitivity to be used for diagnostic purposes. We have been very strict in keeping to this PCR, despite significant challenges by people that should know better on the value of antigen antibody tests. There's no point of saying you have a cheaper test or a test that works in 15 minutes or 15 seconds if that test does not work. So the first thing is, does the test work? In a positive being a positive and a negative being a negative, the sensitivity and specificity. If those two parameters are too low, it doesn't matter if it's cheaper, if it's quicker, and everything else. So we are limited by our diagnostic infrastructure. And yes, we would have loved to do this 60 years ago, but in my situation, I have to deal with the country I have, and not the country I wished I had. So everyone that has heard me present over the last few years, I've been harping on the diagnostic insufficiency in Nigeria. But to build labs are not simple, to train lab scientists are not simple, but this is where we are. So we had 47,000 confirmed cases. We've tested just under 350,000 people. Slide 8 shows the distribution of cases. 35% of all cases are still in Lagos, and 5 states have over 60% of all the confirmed cases. Over 600 LGAs have reported a suspected case, but 85 LGAs have still not done any testing. So we are now really pushing, looking at LGA. We only can present this because we're looking at the data at the LGA level. Now identifying LGAs that have not reported cases and trying to focus on them to really see if they are as quiet as they appear to be. On slide 8 is a very important slide. There are 3 lines. We don't need to go into detail, but the 3 lines basically. The dark orange, light brown line shows the number of tests per week. So we can see that in some weeks we've gone close to 50,000. Of course, we unfortunately lost quite a number recently due to various too many public holidays in a period, but we're now recovering. So, on the average, about 30,000 odd tests are done every week at the moment, and we're pushing to do more. The key line there is the middle one, the dotted green line. This is the positivity rate. So of all the cases collected across the country, what proportion is what proportion is positive? We're now headed more towards the 10%. This has been about that. This graph is about 2 weeks late. So we're trying to keep it down there. Of course, this graph is a national graph and they are differentiated to every state. But we send every state in Nigeria gets a summary of its own data presented and sent to it every week so that they understand the data for their own states and they can use it to make decisions. And Lagos is actually using this very actively. Lagos is down to about 6 to 7% positivity every day. So very good news consistently over the last 4 to 6 weeks. So we're beginning to see a significant decline in positivity in Lagos State, for instance. Talking about the response, this is the structure in slide 11, the structure of the response. We have a presidential task force that coordinates the multi-sectoral response. Then within the Ministry of Health, there's a situation room that is more kind of an information gathering space on different aspects of the response, but the operational public health response is led out of the Emergency Operations Center at the NCDC with various pillars working every single day to support the response and working with the state public health EOCs across the country. So on slide 12, I'll go into just a few highlights on each specific key area of the response. One very important area is surveillance. Now, up to a few years ago, our entire surveillance architecture in Nigeria was based on paper and Excel forms. Over the past 3 years, we have been trying to roll out a digital platform for surveillance called SORMAS. This is a tool that will enable real-time web-based indicators data collected from the local government up to the national level. So we've been trying to roll this out across the country and we keep pushing at it. This has really improved our ability to get data in as real time as possible. Over the next few slides, I'll show you some of the challenges. We also have an event-based surveillance system where people just call to tell us what is happening in their locality and different forms of adaptations of influenza-like surveillance that we've been implementing going on across the country. Now, a bit on SORMAS, because it's very important. This is used for standardized data collection from the bottom up. You collect the data at the local government level, put it into your handheld device. That data is immediately visible at the state level for the state, and at the national level. We use it to understand both surveillance, but you can also use it to assign tasks during an outbreak management and everything else you need to do. So this is really the future. And we're one of the first countries to attempt rolling this out at the national level. The challenge that we had is on slide 14. As at the time the outbreak struck, we hadn't completed a national rollout because it's extremely complex to roll out a new tool to 36+1 states in Nigeria. So the states in pink on the left are the states where we had rolled out SORMAS. So what has happened during this outbreak is that we have now intensified with the resources that have come in, the deployment of SORMAS across the rest of the country. And by the end of this year, for the first time ever, we will have a surveillance tool across the entire country. The slide on the right shows the deployments planned between now and end of the year. So as we have been responding, we have also been deploying a massive new surveillance platform, electronic digital surveillance platform for the country. It will enable us collect some of the data that we have been criticized for not collecting efficiently enough. But these things cannot be done by wishes. They need hard investment, hard training opportunities. We couldn't train for 3 months because we couldn't travel. And while we do things like this online, it's impossible to do online training with people in Borno State at any point in time. So we really had to push wait, and now this is going on. And by September, October, we'll have the country covered. Why is this important? If you look at slide 15, this is the biggest country in the world. The United States does not have, as at today, any system with which they can collect data across the states. This is an article in yesterday's New York Times. As I was preparing for this opportunity today, I saw this article written by Thomas Frieden, who is the former director of USCDC, complaining that states in the US do not, as at today, collect standardized coronavirus data. And this is one of the big impediments of the response in the US. So while we are trying very hard to solve this problem, it's a problem that is global. But what have we done with the data we've collected? We have used it to drive the response locally. All our actions are based on the data we get. We've used it to carry out modeling. What we did was bring together a lot of groups that offered us modeling expertise. They were put together into a consortium. Every week during the lockdown, we got them to focus on specific issues, and they provided us evidence with which we presented to the Presidential Task Force, with which they made these decisions that we had to make every week on our country and how to find the difficult balance between lives and livelihoods. So on slide 17, you will see the different decisions that were made on cessation of movement, implementation of MPIs, and the rest of them, testing strategies. All these were based on the best evidence available, and the best evidence that we could generate was using the surveillance data that we had, use that for some predictive modeling, and this was then used for decision making at the PTF level. On slide 18 shows the progress on the rollout of labs. This slide needs to be updated. There are 62 labs now with testing capacity. We have covered all, but even Gombe in this slide, my apologies, now has a testing lab. So I'm hoping that by the end of this week, there are teams in all the other states working, that we would have been able to completely cover Nigeria and make sure that at least every state has one. And then we keep pushing to increase. We've worked hard to convert Gene Expert platform for TB, Commerce platform for HIV, in order for them to be used for COVID testing. But remember, HIV testing and TB testing cannot stop. So there's always a conflict. At NRL now, the COBAS is used during the morning, and we only have access to the equipment for COBAS at night. So we run a 24-hour shift. The HIV guys use the equipment for HIV testing in the morning, and we use it for COVID testing at night. to do this, you have to pay extra allowances, you have to pay for hotels. There are lots of hidden costs in getting people to work for 24 hours that are not seen. We manage a supply chain across the country. No lab can go out now and buy COVID reagents. So we have to procure this centrally and share this, make sure that every lab understands how much they need today, for the next week, for the next 2 weeks, and calibrate how much we provide each lab, and then organize the transportation and courier of these reagents and commodities to all these 62 labs across Nigeria. So an incredibly complex supply chain operations that happens every single day to ensure that each lab has what they need to test. Over the past few months, the next aspect is we've been developing emergency operation centers. EOCs is a new concept, relatively new, and we saw the importance of EOCs in the polio response and in the Ebola response. But when I started at NCDC in 2016, I went to the venue where the EOC was held in Lagos throughout the Ebola response. That venue looked like something from the dark ages. The investments had gone, the EOC was gone, everything was lost. So we had to start from the beginning to establish EOCs at the national level, at the state levels, coordinate them, and they have become the fulcrum of all the response that we now carry out. We have an expanded warehouse in Abuja right now where we store our response commodities, our personal protective equipment, and all of that. And we have made sure that every week commodities are going out to states, to FMCs, to UN, to teaching hospitals. So any of us here working at a teaching hospital, the CMDs, any of you are welcome to speak to the CMDs of how much supplies they have received every week. The last aspect I want to focus on is on risk communication. This has been an important part of this response because we really have to win over people's trust. We cannot enforce public health measures. There are very few public health measures globally that have ever relied on enforcement. Seat belts are the most commonly quoted one. The other maybe is sometimes smoking in public places. But every other thing, whether it's every other thing relies on convincing people on behavior change. And this has traditionally taken years. So we're trying to really convince people on a whole new set of interventions within weeks. So it is hard. And very few other countries in the world have actually succeeded in doing so. But we have been pushing, and we haven't stopped pushing from the very beginning. We started a campaign called Take Responsibility, so that people take individual and collective responsibility for what they're doing. We have a dedicated microsite, covid19.ncds.gov.ng. This is the site. You'll be surprised that supplies a lot of the information across the continent. Many countries have been adapting our guidelines and using it for their own purposes. So I will end with a few words on the integration of science and policy into our work. When there was a lot of noise about research, but nobody was actually doing anything. And research is hard. So we sat down with DG of NIMA and said, listen, let's bring people together. It's one thing saying nobody is doing research, but let's actually do something. So we brought DG, we went to NIMA, we went to the Nigeria Universities Commission and Tech Fund. We spoke to the chief executive, we brought them together, and we sat down collectively to form a Nigeria COVID Research Consortium. You know, whenever NCDC leads on doing something, at the end of the day, we get a lot of criticism for doing stuff. But, you know, we can't wait. Our country is in a hurry for results. So we brought colleagues together, we put them together, created 8 technical areas of endeavor, and these groups have started working together on these areas. What we have done in-house is support the validation of test kits, of extraction kits. We always push to work together with sister agencies, NIMA, MLSCN, and the rest of them. We've validated about 10 RNA extraction kits at the moment. Whenever people bring new kits, we look at it, we validate whether we can use or not. And we are now rolling out quality, external quality assurance for all the labs currently involved in testing. The other key thing is realizing that we can't do this on our own. So very early on, we worked with the Africa Center for Excellence for Genomics with Professor Happy and his group at Redeemers University. And we worked with him in the genetic sequencing, the first one out of Africa, and reported that collectively, brought together Lagos State Government, NIMA, and did a report collectively as Nigeria and sent it up. And our genome was the first African genome reported for COVID-19. We have now done a lot more, and we're working with the Africa Center for Excellence to collect samples from all over the country. So we're not just saying these are samples from around Ede where he is, but making sure that he has a wide spectrum of samples from across the country to provide the geographic diversity he has. And those are presented in slide 25. And from this, we will try and learn both for adaptability for the response, but also for vaccine development on whether the vaccines being developed are appropriate for our own context. The other thing that doesn't get a lot of mention is social science. You know, if you see our social media response, what we respond to is not random. Every week, we collect data on what people are talking about, on rumors, on social media. We look at it every Friday, and from that data, we develop the messaging for the next week. So today, they might be talking about mass. The next week, they'll be talking about cures, or Madagascar cure, or Chinese doctors, or whatever the flavor of the day is. What the team does is analyze all of that and respond to those specific issues, and making sure that there's a scientific underlying basis for all our communication. What research outputs do we have? We have quite a number of papers defining the epidemiology in Nigeria, the response in Nigeria, the risk factors leading to either positivity and deaths, all are different. Some are in peer review, 3 of them are in peer review already, 2 of them are in development, and a series of others that will go out, all using nationally collected data, acknowledging the role of the states and other national actors, and providing the scientific community a picture of the epidemiology of this virus in Nigeria and the response to this virus in Nigeria. We are also participating in a few of the WHO protocols, both in terms of the disease and the response. So in conclusion, and this is my last slide, our priorities moving forward is really to support the states. We don't, at NCDC, we have made a deliberate decision not to set up state offices. We want to support states. States are the fulcrum and will be the fulcrum of the public health response in Nigeria. The responsibility of our agency is to support the states to grow their capacity to do that. So recently there was a World Bank opportunity for funding. We have worked with the World Bank to get the funds. We are deploying it to be used at the state level, supporting the states to use it and to account for it, and therefore we get the best value for our country. There's no doubt that testing will continue to be important to understand the scale of the outbreak. So at the moment, we're supporting states to set up new sample collection centers and increase the testing capacity. We want to contribute and make sure Nigeria is contributing to global research efforts through the WHO coordinated trials and work in collaboration with other agencies. The critical final point is for every investment we make right now at NCDC, we have 2 goals. One is to respond to the outbreak that we are facing. The other is to make sure that we are better prepared for the next one. So whether we're building out lab infrastructure or EOCs or treatment centers or supply chain, we are building a platform for the future. This is our responsibility to Nigeria. No matter how bad things are now, what we cannot do is go into next year or next 2 years, face the next outbreak, and be talking about the number of labs or number of EOCs or supply chain. So we are really building a platform for the future, and we need your support, we need your voices, and very grateful for the opportunity of sharing a few thoughts with you this morning. Sorry I have flown over for a few minutes. I'm deeply apologetic, but I hope that this adds to the conversation. Thank you.
No, there's no need to apologize, Dr. Ihekweazu. We are very happy with the information you shared with us. And if it took those extra number of minutes, so be it, because I am sure in going through your presentation, you have taken care of quite a number of questions that would have arisen as the webinar went on. So thank you very, very much for bringing us up to date about what your center is doing and how you are preparing for the next pandemic. That's really, really encouraging. That when, because it's not a question of if, it's a question of when the next emerging biological agent comes around, that we will be better prepared to confront that challenge. So I will go on now to call on Professor Hussaini. He's done a lot of work developing local herbs for use as medication for various ailments, particularly to confront infectious diseases and cancers. So I'm sure he has quite a lot to share with us from the point of view of how the medication that can be deployed in combating the COVID-19 challenge. So I would like to call now on Professor Issa Hussaini to make his presentations. I hope he can stay within the 10-minute timeline that has been set. Professor Hussaini, you have the floor, please.
Thank you very much for the invitation. Can you see my slides?
Yes, we can.
Okay. So thank you very much for the invitation. This is a very important opportunity for the academic of science and all scientists in Nigeria and all over the world to address this important problem. So fortunately, the DG of NCDC has taken care of all the things, so it's going to save my time. So this is all about COVID, where it started and when it started. So this is just the symptoms, because if you don't know the symptoms, it's going to be really difficult to treat the disease. So dry cough, fever, shortness in breathing, blood clotting, which is also very important. I will talk of why we use aspirin or advise patients to take aspirin. It's mainly because of this blood clotting. And then this is mainly the agent that causes COVID. So it's a positive sense RNA virus. So two ways of really detecting it: real-time PCR and ELISA using antibody, which the DG has already mentioned. So the first case is this Italian who was reported in Lagos, but in Maiduguri, Borno State, our first case was in April, on the 19th of April, 2020. So the Borno State government set up a tax committee, a high-powered committee. I headed the committee, and we were given 2 weeks to find how this patient got the virus, and then how he was managed. And then we also, it was also in terms of reference to recommend measures to take to really stop the spread of this virus. So after analysis or investigation, we found that actually he had not traveled anywhere. So most likely one of the NGO staff who traveled abroad must have infected him. So what we did, we established contact tracing committees, and they traced all the family members, all the people that came in contact with him. And within few days, they were quarantined and they were screened. And after that, we took measures on how to prevent this transmission of this virus. And also we blocked entrance to Maiduguri by screening all passengers coming into Maiduguri. So even before, when the federal government was planning to put the lockdown in Lagos and Abuja, we were also planning to do the same thing. So we instituted a lockdown for first 2 weeks. That was in April, May, and then after that, another 2 weeks. And really that helped in reducing the transmission, even community transmission in Maiduguri. And then we established, in collaboration with NCDC, a lab because we had a polio lab, and since now we don't have polio, so we use some of their facilities. Their real-time PCR established that, and we started screening. So no need to send samples to Abuja, you know. So these are some of the positive things we did, but I will tell you that the contact tracing committees, they played a tremendous role in really reducing the transmission of COVID in Borno State. So these are the cases which the DG has mentioned. This is real time as of yesterday. So globally, this is what's happening. And then if you look at Nigeria, this is as of yesterday. So the DG also mentioned about the total tests, which is 319,851. We really have to do more because other countries are talking of millions. So this will really determine how many cases we have. So it's important that we really revamp this, but by increasing the testing sites to about 62, definitely more samples will be tested. And this is a very important slide. I really like it. It's from New York. If you look at the age group and look at the rates, this is death. You will find that younger generations, because of their immunity and other factors, they don't die as easily as elderly. And if you go to 65, 74, or above 75, this is where you see real death. So this informed us that we have to take off our elderlies, considering that in Nigeria, the life expectancy is like 56. So you could see that we are doing very well and people are not dying as many as in other countries because of this young population. So, but in Borno State, our focus now really it's on our elderly and also people who have like asthma and diabetes and some cardiovascular diseases. So this is from daily average daily COVID cases in Nigeria. So I used the CDC, NCDC data. You could see June, if you divide the total number of cases in June, that's new cases, by the number of days, which is 30 days, you come with that. And there was an increase in July. You could see it went as high as 569. But August, even though we are just about 11 days or 10 days, you could see that it's dropping. So the new cases really are dropping. But the other exciting thing to me, it's really looking at the mortality rate. So I plotted, this is using the data of NCDC. This is as good as really current as of yesterday. And you could see in May, the mortality rate per day, it's really high. Then June, less. July and August, it has really come down. And as of yesterday, it's just 2.2 compared with what's happening in the rest of the world, because the global distance is about 3.63, US 3.16. So Nigeria is doing great with 2.2 mortality rate. So my focus, it's really, it's in finding treatments using either orthodox or our own traditional herbs, because we have to think outside the box. We have to use what we have here. So if you look at globally, people have used hydroxychloroquine, antivirals, dexamethasone, and then antiplatelet aspirin. This is what we are using. And then some of these immune boosters. So the hydroxychloroquine, it's very controversial. Some studies have shown it's effective, but the clinical trials, especially in US and WHO, showed no difference between people who took hydroxychloroquine and people who have not. Antiviral, this one, it's really the one that people are using in combination with sometimes with even hydroxychloroquine, but it's used also for Ebola and other antiviruses. other viruses. Dexamethasone, there was a study in UK, I think, where they showed that especially patients that require oxygen on admission, they do better if you give them dexamethasone. Not every patient. So this is also important, showing that at least there is this component of anti-inflammatory activity. And the reason why we give aspirin, aspirin stops platelets from aggregating, and it selectively blocks the production of thromboxane A2 without affecting prostacyclin, which is the good prostaglandin. So as a preventive measure, it's really good. So because of the study from Italy that really patients with COVID, they died from clot. So if you give a drug that stops clot formation, that would be great. But it's not going to be useful once the clots are formed. So some colleagues of mine in US and Europe, they are looking at some of the thrombolytics. And the thrombolytics, what you do, it's you give them and they destroy the clot. So if the clot is formed, this is the way to go. But for preventive measures, aspirin is better. Why do we give immune boosters? We give vitamin D3 about 1,000 units per patient, even though the required daily dose is about 400 units. And then this habatus sauda, black caraway, it has been extensively studied. We have studied it, and it's not toxic at the level we are using. And sometimes we add onions and garlic as well. And then, of course, the Madagascar, they use this Artemisia anuca. We don't use it here for COVID, but we use it for something else in addition to malaria. Vitamin D, there is a study that showed that patients with COVID, 58% of them, if you give that, it's lack of it leads to mortality. So that's why we give it, so that in case patients are with vitamin D deficiency, they will be protected. Black caraway, that's Nigella sativa. We have used it, except it has antihistamine activity. It has been proven over and over and over again over the last 30 years, anti-inflammatory, antiviral, but nobody has tested it directly on the SARS-CoV-2. So, but that's the reason why we use it. It has antibacterial activity as well. So this is the combination we use. The N-sativa oil, 1 teaspoon in the morning, 1 teaspoon in the afternoon. And then we give vitamin D3, 1,000 units, aspirin, 75 milligrams. So this is the baby aspirin. And the first study we carried out in our isolation center, it's that all the 36 patients, they did not develop any symptoms, and they were discharged, some even within 1 week, some within 2 weeks. So it's ongoing. And for preventive measures, actually, we have recommended it to all our elderly people in Maiduguri that this is what they should take. Because during the Ramadan, sometimes in April, we had about 10 or 12 of our elderly people died. But following this now, I'm glad to say that really the cases of COVID death, it's very low in Maiduguri. And then there is a study from Medina, which they use the same black caraway and some other spices. They also showed really good effects with this black caraway. We have not done clinical trials. We have not done any double-blind studies. We are just trying to save lives. We are trying to protect COVID. And these substances, N-sativa oil, vitamin D3, aspirin, they are not toxic. And we were expecting the government to say, okay, come, let's see, prove to us, show us that this is effective, but nobody has done that. And we have talked about it and nothing has happened. So now the best play area is vaccine, and vaccine takes time. So without that, we have to rely on our herbs to really prevent COVID transmission. And these are some of the hot vaccines. And just yesterday, Russia came out with this Sputnik V that they are claiming that is their first vaccine against COVID. And so far as today, there are 5 vaccine candidates which are in phase 3 of clinical trials. So my appeal to the states and federal governments is to challenge the academy, the National Academy of Science, and provide substantial funding to find cure and vaccines for COVID. Because if you can recall, JFK in the 60s challenged Americans to land an American on the moon in 10 years. By 1969, the first American landed on the moon. And George W. Bush challenged scientists to sequence the human genome in 10 years. That's 1995 to 2005. By 2003, it was done in 8 years. So what I'm appealing for our politicians or government to really challenge the academy, challenge the scientists, but not just challenging verbalism, you back it with money, funding, and we can find cure for this COVID-19 and other diseases. But we don't challenge scientists, we don't provide funding for science. And I'm not talking about 10 million, 50 million, 100 million, I'm talking of billions. You know, the academy can give 5 billion, get best brains, try to find vaccine for COVID, try to find cure for COVID. So this is serious, and within the shortest possible time, 6 months, a year, this one can be done. You know, especially for cure, the vaccine, of course, it will take time, probably 18 months or 2 years. But if you put the best brains there, all the things can be done. Thank you very much for listening. I will accept or I will welcome questions.
Thank you very much, Professor Hussaini.
Thank you.
Hello, yes, thank you for your presentation. We will quickly move. I mean, when you are appealing to politicians and governments, that sounded very much like appealing to yourself. So I hope you do something in your own little corner of the country to move this forward. So now let me call on Dr. Bodila Dipo, who is at the front line of actually caring for patients who have been diagnosed with COVID-19. And let him share with us the experiences they've had at the Emergency Operations Center in Oyo State, the network of isolation centers that they are looking after. And I know that Dr. Ihekweazu says they are gathering data from the various parts of the country, and many manuscripts are in preparation. But you can give us a bird's eye view of what you have been doing so far in your network of isolation centers. You are very welcome, Dr. Ladipo. Please, you have the floor. Thanks for sharing your slides.
Good afternoon, esteemed co-presenters. I am so very much humbled to be in this gathering. I hope my presentation is seen by everyone.
Yes.
Thank you very much, sir. Oyo State has a total of 2,887 cases as at the 11th of August. And those arose from about 40,500 tests that had been conducted so far with 31 days. This slide talks about how we've come to our point in the state. Our first case was on the 21st of March in 2020, and we had slight increases as we went along. However, the state took up an initiative of having to expand testing, and our testing went across 11 points, 12 points really. 10 of which were community testing centers that goes across the length and breadth of the state, the University College Hospital, and another that is a drive-through testing facility that was put together at one of our stadia in the state. And that gave those large numbers that we saw. We saw the first around the 22nd to 23rd week of the response, and then another phase of community testing came up when we started integrating into the existing structures on the general hospitals. And those are culminated in the numbers that we see. In the state now, what we looked at the age and sex distribution is actually what we're seeing now, with the most affected groups being in the productive age bracket of 25 all the way to 69. We actually see quite a number of those that are in their late 60s, and those were with comorbidities, and we've had very little choice than to have them hospitalized within the state facilities. There is no LGA within the state that is exempt. Initially, we had some of our local government areas, especially towards the core north of the state, not having any cases. And that was due to the fact that our testing centers, the sample collection areas, not reaching those areas of the state. But with expansion of the sample collection centers to every part of the state, we've been able to note that there is no LGA within the state that is exempt. We've been able to look at the kinds of cases that we've had in the state. Most of them seemingly have no symptoms, and but we are actually reviewing those now, asking questions from those cases, and at times most of them come to the realization that there might have been some brief period of fever, perhaps a loss of smell that was not taken seriously into cognizance, and that is why this acceptance that they were asymptomatic came on board. Across the state, most of the cases that we've seen were with fever. But the ones that are really striking is the fact that when we have loss of taste and loss of smell, it's almost an indication that those cases were related to the COVID-19. All the cases that presented with loss of taste and loss of smell had come down with a positive test in the state. And because of the issues pertaining to social mobilization and risk communication across the state, we decided to look at what the public trust is about. And we realized that the public really do not have so much trust in government, politicians, and what we found is that majorly people are looking towards family members, healthcare workers, and more interestingly, the religious leaders for guidance in terms of information. And that has actually informed our decisions to look towards those channels for our mobilization activities in the state. We also looked at it across LGAs, and the slide that is showing now depicts what the risk perception across Oyo State is about. We realized that people still believe that this affliction is not so much of a concern to most of them, especially as we drive out of the city center in Ibadan and going towards the hinterlands of the state. And that is one area that has been giving us a lot of concern, and a lot of effort is still trying to put in place to ensure that people do understand what the risks are about and how to make sure that people would follow the protocols that are set for the reduction of transmission of the disease. We've been able to look at our system in Oyo State in terms of what we are able to do in terms of strengthening the structures. We've been able to repurpose our healthcare facilities towards the pandemic. For instance, we've been able to look at the facilities at the Olodo Center that used to be an infectious disease center, which I'm glad that the DG NCDC had actually visited. And his comments had been that that center will actually serve the southwest of the state, of the country, more than even the state itself. Other centers have been put in place: Awe, Jericho, Ogbomoso, Shaki, Igbora, and the University College Hospital, Ibadan. And the spread of those isolation centers actually covers the state and make sure that there's no part of the state that will be left behind in terms of care and management of cases. And the good part of it is that those structures are existing structures in the health system. If the pandemic actually goes back, these structures will be plowed back into the same system of healthcare service delivery, and that would augur well for the state. Another area is the issue of manpower development. That has actually gone far and wide across the state, and there is virtually no part of the state, no level of healthcare provision that has not been touched with capacity building, such that the areas that were met when the COVID-19 pandemic came up in the country is not where we are now. And that has actually been some good parts for the state. We've been able to look at the community testing, as I mentioned earlier, and that has helped us ramp up the numbers of community samples collected across the state. When we started the community testing, we were just about barely 2,000 tests done in Oyo State. And as we speak, we have actually been able to go above the 14,500 tests collected in the state. And that is being integrated into the existing health structure. The general hospitals have come on board, and we are putting all efforts to make sure that sample testing, sample collection is done at general hospitals such that it falls into place with what exists already and will continue going forward. The final part of it is the activation of the rapid response teams across all the 3 LGAs. The medical team at the local government level is being activated to look at the issues pertaining to surveillance, case finding, as well as contact tracing going forward. And they will be responsible for giving the feedback to the state and ensuring that the cases that are seen are well sent to the various isolation centers across the state. The management structure for this response in Oyo State has on its leadership the task force, which is chaired by the governor. It's a 24-member committee, which the incident manager of the EOC is a member. And the pillars, just like the EOC of the federal, is in place, with an additional secretariat that coordinates the activities of the daily activities of the EOC. Looking at what the state have been able to do, we still have to look at the challenges that we faced. The initial part of it was the problems with the international border and serious restrictions not being in place. The international borders that Oyo State has with Benin Republic gave the opportunity of persons crossing the land borders, especially on unmanned areas, to enter the state. And unfortunately for us, when the pandemic was almost coming to the fore in full force in the state, it coincided with the planting season, and quite a number of the people that were coming into the state were migrant farmers that were, interestingly, were initially part of those that were tested positive in the state. And that gave quite a number of concerns that we had to have a serious dialogue with the immigration services to ensure that this was mitigated against. Another issue was the issue of the interstate movement, especially during the lockdown. Quite a lot of movement was still going on, mostly because the state allowed movement of goods and services to be going on, and quite a number of individuals were coming in from various parts of the country, and unfortunately too, we found some of them positive. And those were those areas that set up the community transmission as we saw it in the state. The last one about it is we're not having conflicting issues with tests based on public health needs versus the requests from other individuals for tests. Quite a number of test requests are coming up by people that want to perhaps travel. Perhaps schools are reopening. Some schools, especially the private ones, are requesting for tests of certain parts of their staff work or even the students before they resume. And that is something that the state is looking into to ensure that we have judicious use of the public health response going forward. The management of resources is what has really come from that. And then the last one about it was the issue of the public response to risk communication. There is poor compliance. There has been so much of advisories and guidelines that have been turned out by the state. However, the issues pertaining to enforcement or compliance by the public is still being looked at. The poor risk perception is still a major problem, and that is what we're seeing in terms of the challenge. Because of that, we intend to have a more robust public enlightenment, the full implementation of the rapid response to ensure that all the local government areas of the state are adequately carried along, and more so, the issue of sample collections into the existing structure has been started. We intend to integrate it fully and also expand it to cover all the general hospitals within the state. And with that, we expect that we'll be able to have a better idea of what the pandemic looks like within the state, and be able to make very good decisions going forward in terms of where we need to put in our responses and our efforts in the state. Ladies and gentlemen, I hope I've been able to keep within time, and I wish to thank you, and I thank you so much for the opportunity.
Thank you very much, Dr. Ladipo. We've really gone way above the time scheduled for the actual presentation. So the time available for the discussion has been considerably shortened. I want to thank all those who have turned up for this webinar. I could see quite a number of distinguished personalities represented in the lists of attendees, vice chancellors, excuse me, please, vice chancellors, distinguished professionals, fellows of the academy, and so on and so forth. Thank you very much for showing up. It will not actually be possible for us to call on the attendees to put up verbal questions or make comments. Everybody would have to make the comments into the question and answer panel. And I would want to urge all the panelists to look through the question and answer panel, and I will call on each of them for 5 minutes to take the questions that they feel most closely address the issues that they have brought forth in the course of their presentation. And so in that 20 minutes, more or less, we would have covered all the panelists. They would have had an opportunity to respond to those questions that have been posted in the question and answer panel. So if you still have any question, please put it in the question and answer panel, and then we will take those questions from there. So let me start by going back to the lead speaker, and that's Professor Tomori.
Moderator, just a second.
Okay,
I'm sorry.
President.
I'm very sorry to interject, but in between, the NCDC DG has another meeting. I was just trying to get to you before you reached here, whether, I'm not even sure he can take all the questions have been directed to him. So if it's possible for him to take a few then before he exits, then the rest of us can continue.
Fine, so maybe Dr. Ihekweazu can start off.
That's the idea.
5 minutes to address the questions that you think are most burning among the ones that have been.
Because he has many.
The question and answer panel. So just take about 5 minutes or a little more to address those questions. And then next we will go to Professor Tomori. Dr. Ihekweazu, are you there?
Maybe he has already taken his exit. You didn't see he sent you and me. He sent us a note.
Oh, okay, I did.
Why the last speaker was writing, or maybe I didn't even know he has taken his exit.
Yeah, I think he's left.
Okay, he must have left.
So we just go on.
Some of his devices are still here, so we'll just ask Professor Tomori then to.
Yeah, it's okay.
Questions that he feels are most pertinent to him.
Yeah, thank you very much, sir. And thank you for the presentations. And actually, I wasn't asking any question, but I think the point I want us to raise is that when we're talking about state authority, I think we should get out of that. In a national emergency, there's nothing like state authority. All these powers is, and that's why I said initially that maybe the president should have called all the governors together at the beginning and got their consent. Because right now we're being hampered by this so-called state authority. I talked with Chikwe before about this type of, and he says states are keeping some of their results, they're not really, until they release them, he can't say anything. And we know some states are not even releasing results. I know of states where, they said they're running studies or something, but they're going the wrong way. Nobody has control of what the states are doing. But when you have a national emergency, I think we should speak with one voice. And I think, I don't know why, sorry to use the word, my president is afraid to call all these governors to order. We have the national emergency in our hands, and we should act like that. That's the only point I want to raise. And until we do that, forget it. We'll be getting all these kind of things. I keep saying it, sorry to point out to Kogi is still doing what he wants to do. Crossover is complying, grudgingly. They're not really getting down to this thing. These are the issues I think we need to address. And on the other issue about science and researchers and things of that nature, one thing that we have with this kind of government we have is that they set up committees, and committees give recommendations. Till tomorrow, you keep asking, where's the recommendation? What has happened to it? Nothing. It is just because we have faith in our country that some of us are still sitting on some of those committees in the hope that something will happen one day. Because if we keep quiet, nothing will happen. Even when we're talking, nothing is happening. So we keep talking until something happens. Like Chikwe says, we keep pushing. And we push on and push on. Now when people give recommendations and all those kind of things, then even if you are not taking the recommendation, give the reason why you are not. And then people can look at the situation on that. Finally, on back to making use, research is not test tube and what do you call it, reagents and things. Research also means looking into those data that you are collecting. I'm doing a study now of the different African countries and seeing how they are doing their distance. I've seen one or two things that when we get a result for today, for example, today or yesterday, there were about 20,000 samples added on what they call backlog. Where did they come from? Is that part of the positive? Is that part of the negative? You know, all those are questions that, you know, we are not, the research we're asking for is not carrying the test tube and something. Those basic things are research in themselves, and they are more what we call operational research, and they help you plan better. That's what we're asking. You know, and I don't think anybody thinks that I'm going to use the data there for my PhD now. I don't think so. So, I mean, get all the best of your people, and they're ready to offer in this time of lockdown. We have plenty of time in our hands to help our country. That's all we're asking. Over.
Thank you very much, Professor Tomori. Let me move on now to Professor Hussaini to address some of the questions.
Maybe we should check whether, sorry to interject, sir, to check whether the NCDC DG is back. I've been speaking to the office through a back channel.
Okay, well, he had 3 devices on before. Only one is left. I don't know.
Yes. So I think they're supposed to contact me once they've checked his office, particularly to be sure it's there. But
yeah, if he's back, we would like to listen to him, because most of the questions are actually directed to him.
Okay, so once they let me know, I would allow you.
Yes, so yeah, but it's still not here. I mean, he still has one device connected, but I don't think he's attending to that device. So let me go to Professor Hussaini. He asked quite a number of questions. A lot of people want to know more about this N-sativa oil and so on, black caraway oil. So, so please let us know what's happening about it. I know people just want to look into medication, but we need to be really careful to conduct proper clinical trials before we push these things out into the public domain. But Professor Hussaini, please, can you shed more light on the black caraway oil and how you have used it?
Yes, and someone asked the composition of the black caraway. So what we use here is oil, and lots of clinical trials have been carried out in toxicity, different countries. You just Google, you will see it. So, but not targeting, let's say, COVID-19. So what we use is the oil. So the oil, we give 1 teaspoon in the morning, 1 teaspoon in the evening. And you can take it as 3 months, 4 months. So far, we have not detected any toxicity. I took it and I looked at my kidney function, liver function, and in rats, we have given tons of this thing, and it's relatively safe. And the other question someone asked me, the composition, actually we don't know the composition, but we have identified a compound called thymoquinone. Thymoquinone is a quinone, and it's solely responsible for its anti-cancer activity. We have not tested it on the coronavirus, SARS-CoV-2, but as I mentioned some other viruses, people have used that thymoquinone as well as the oil on them, and they are very effective. And someone also asked whether we mix the oil with aspirin and D3. No, we don't, because aspirin 75 milligram, you can get it anywhere. You know, you go to any pharmacy, you ask, they will give you either 75 milligram if it's UK based. If it's US, it's 81 milligram. And usually it's recommended for elderly, not only for COVID, for heart attack. Because once you are taking it, platelets will not aggregate and clot will not be formed. So in most countries, they recommend elderly people to take this baby aspirin, 75, 85 milligram, 1 tablet every day. And then the D3, we are recommending 1,000 units every day. So we take, we give the patient separately or people to take it separately. Believe me, we tried on even almost someone, you know, he was coughing, he thought he would die. Quite a number of elderly. We put them on this. After a week, 2 weeks, they recovered. Because as I mentioned, during the Ramadan, May, April, we lost about 10 elderly people in Maiduguri alone. And based on the results, you know, they said COVID, because some of them are 81, two of them were even 90 years old, and they had symptoms of COVID. Unfortunately, at that time we had not started, but later on we devised this in all our elderly people. We recommend, we give them the black caraway oil, vitamin D3, aspirin. Some also take garlic and onions, because they are good for even cardiovascular diseases. So whatever that will really protect our people, we are going to do it until we have a vaccine or we have a drug that is a cure. And this combination, spices and all these things, is part of our diet for centuries, because historically it dates back to almost 1,400 years. People have been taking this oil for prevention, even cough and other things. But aspirin is based on the fact that patients that have COVID, they die of blood clotting. And antiplatelets are good for preventing clot formation. So this is our own thinking of doing it. So to do clinical trials, we are not going to wait for all these people to die, and then we start saying we are waiting for clinical trials. And if the government, you know, is going to fund it, because we try to apply for even funding, you know, apart from the ones we got from the government to keep us going, we have not received any substantial money to do clinical trials. So that's what I have for now.
Thank you very much, Professor Hussaini. So finally, we go on to Dr. Oladipo to respond to some of the questions that have been pasted on the question and answer panel.
Thank you very much, Prof. I have a question from Dr. Okong from Calabar, and he was asking whether there was the evidence for transmission of from asymptomatic cases. I recall that I spoke that some of these so-called asymptomatic cases could have had some symptoms that were not well identified by the client or even by the health worker when they were seen. But when the tracing were done for some of those cases that we saw that, in quote, had no symptoms, we found some of their contacts coming positive. So I will say that, yes, we cannot relate out that there is transmission within that cohort of people, but also we need to understand that in this environment, the people that claim to be asymptomatic could have been having one symptom or the other that might have been overlooked before now. So the evidence of transmission from asymptomatic, thoroughly asymptomatic people cannot be ascertained. But then we do know that those that we categorized as asymptomatic are actually having people that come down with the virus based on contacts with them. So that is the best I can say for now. We are still looking at some of those parameters as we had them in our data. We are following up with some of our clients, and we will be able to confirm the evidence soon enough. But the evidence shows that, yes, there is some transmission even with people with very low or mild symptoms, and that we consider to be asymptomatic. Thank you very much, sir.
Thank you very much, Dr. Oladipo. So we just have a few minutes to wrap up the webinar. There are quite a number of questions that have been asked. There are questions about the academy. So maybe I would ask the president of the academy to say a few words on what the academy has been doing to support the COVID response nationally, and generally to educate attendees about what the academy does.
Okay, we have been doing our bit. First of all, we belong to a network of academies in Africa and in the world. And we've been partnering with them. We've released a lot of statements. Our first statement on COVID was issued quite early, sometime in March, because we had an idea, even when many Nigerians didn't know, of the kind of thing we were getting into. Nobody would have claimed to have seen all the where the virus would mutate and all the things that it bring. But some were definitely, we could note some pattern that was emerging. And we have experts among us. Some of them, somebody like Professor Tomori has been very active, even on a personal basis. And then we issued statements. We joined other academies to issue statements for our continent. And our members are serving in various panels of experts. We voluntarily produce our people. There's even their own expert panels globally and continent-wise too, because the African Scientific Research and Innovation Council, formed by the 54 nations of the African Union, they are also active in looking at how we in Africa can be protected as much as possible. Our experts, members of the academy, are actively working in that. There are questions that have been asked. For example, one of our elders, Professor asked about capabilities and existing facilities. The academy is doing its best with and we always do. After Ebola, it's on record, the academy organized a seminar. We brainstormed, we brought all the key actors, including the chief medical director of that hospital in Lagos that handled Ebola, and the people that recovered, the young doctors, and they came. We shared experience. The whole idea was preparing for the next pandemic. Because just like the NCDC DG was saying, you never know what's around the corner. It's not and the moderator has said this, we don't know when, but we suspect there will always be something. And so it's to learn. We did all that, and that report is available, even to government, as a proceedings of the academy, on why we reviewed the whole Ebola thing and gave suggestions for future. I'm not sure how many people even remember that publication. So the academy does its bit, and we are also involved in trying to coordinate research. And we are doing, leading a consortium of people working on various aspects of the COVID thing. Some of them are still in the pipeline. We're working very hard. And of course, we are actively involved in discussing with government. The Federal Ministry of Science and Technology has been very active. The Minister of Science and Tech was the first at the beginning of the year. Before the index case came in Nigeria, once the virus was noted, he offered a challenge. He asked any Nigerian, said 37 million or whatever, and went ahead to put up structures, even to validate what anybody brings. So a lot of things are going on. They involve the academy. We are doing a bit. That's all for sure.
Thank you very much, President. We have just a few minutes left, and I just want to touch on some of the questions that have been raised in the panel. Unfortunately, the Director General of the NCDC had to leave before the end of the webinar, and I don't think he's been able to come back because many of the questions were directed at him. But a lot of the questions are also, they illustrate our society's emphasis on looking for medicinal cures. So many people asking, of course, about the black caraway oil that Professor Hussaini talked about, but so many questions about the use of antibiotics, about the use of hydroxychloroquine, and so on and so forth. I think the message that should go out to the general public as of now is that your best bet is prevention. Those preventive measures that have been emphasized since the onset of this pandemic, making sure you maintain physical distance from people wherever possible, using face masks, and washing hands as frequently as possible, avoiding handshakes, and so on and so forth. In terms of what medication that is effective, the only one that has been shown to affect the virus in any way, and its action is marginal, is remdesivir. All the others are speculative or they are supportive in the kind of response that they offer. For instance, so the steroids that were mentioned earlier on by Professor Hussaini, dexamethasone, for patients who are seriously ill, that can moderate some of the pathology of the sickness, and maybe it can prevent some deaths from occurring. But it's better not to get the virus in the first instance than to have to be depending on the use of medication to deal with it. I think the problem is that many members of the public do not want to do those things that can at least offer them some protection from contracting the virus. But that's what we need to do. It's often unpleasant. It's often irritating, really. I mean, not to be able to hug somebody that is your friend and you hadn't seen for a long time, not to, I mean, you have to wear a mask when you're in a public place. But for now, that I think is our only hope to deal with the situation. I am not sure that the arrival of a vaccine will actually significantly alter the situation. What may help much more is if we have effective medication that actually either minimizes the effects of contracting the virus or acts as a prophylaxis so that the virus is not able to establish itself. But vaccines have their own politics and all kinds of other conspiracy theories around them. And the problem with vaccines is unless you cover a great chunk of the population, then the community will not derive the full benefits that we ought to be deriving from vaccines. You need a minimum proportion of the population to be covered for vaccines to be effective. So I want to thank all those who have been able to attend this webinar. I'm sure we have all learned one or two things. I want to apologize that we've not been able to tackle many of the questions, particularly those that were directed at the, directed towards the Director General of the Nigerian Center for Disease Control. But we have captured many of these questions that you've put in the question and answer panel and in the chat box. And for those who registered, we'll try to get responses. And there will be an official publication from the academy to summarize many of the issues that have been discussed at this webinar. So that, there will be a kind of record for people to make reference to in future.
Yes, that is correct.
So I would like to give the last word to the president of the academy before we close the webinar.
Just to thank everybody for being there, especially our resource people, Professor Hussaini, Professor Tomori, Dr. Budeladipo, and the NCDC DG. I want to thank all of you very much. Look out for the next webinar from the academy, which will not be too long from now, on another touching thing that which will make public then, but concerns all of us, concerns science and what we should really do and what the government should do. We'll announce that in due course because it's important that we survive this era. So I just want to thank all of you for being part of it, and especially those behind the scene at our academic secretariat, our executive secretary, Dr. Doyon Dubanjo, and team who are at the background putting things together, and our resource people. I thank you very much. Our fellows, great fellows who, some of them, when they made comments, it was great to know that they remembered to log on, and people who are also listening to us from even beyond Nigeria now. Watch out for our next seminar, webinar from NAS. It's not going to be too long from now. There are many critical issues affecting our nation, Nigeria, about which decisions need to be taken, about which you need to understand the science that should guide those decisions. And we'll discuss them in due season. Thank you very much for being part of it. Thank you, moderator. You've been excellent too. So
thank you very much. So I think we can declare the webinar closed now.